Hi everybody. Today we'll read together the Extremity Trauma from Bailey and Love. During the reading, I'll try to highlight and elaborate the important points and concepts. So let's read together. The learning objectives in this chapter will be how to identify whether an injury exists, the important injuries which should not be missed, the principles of the description and classification of fractures, how to describe and classify fractures, the range of available treatments, the treatment options which we have for a specific fracture, how to select an appropriate treatment. So let's start with introduction. In several chapters, the importance of life-threatening trauma is emphasized. In this book, the life-threatening injuries we have already studied and discussed. So, can you name the life-threatening injuries? The deadly dozen? 6 of them are immediate life-threatening and 6 of them are potential life-threatening. The immediate life-threatening are also called lethal 6 and potential life-threatening are also called the hidden 6. So, which are the lethal 6? Immediate life-threatening. Number 1, airway obstruction, then tension pneumothorax, open pneumothorax, massive hemothorax, cardiac tamponade, and flail chest. What is flail chest? When 3 or more ribs are broken at 2 or more places and a segment is created which moves paradoxical to the rib cage. When the rib cage moves inward, that segment moves outward, and when the rib cage moves outward, that segment moves inward. And it interferes with the breathing of the patient. And what are the hidden 6? Those are aortic disruption, tracheobronchial disruption, esophageal disruption, cardiac contusion, pulmonary contusion, and diaphragmatic tear or rupture. So, extremity trauma can be thought of as injury in isolation or in context of trauma to the whole body. There can be extremity trauma with an isolated fracture like fracture of the tibia, fibula, femur, radius ulna or humerus, or there can be extremity trauma associated with trauma to the whole body like closed fracture of the tibia with a tension pneumothorax. In such cases, we first resuscitate the patient according to ATLS protocol. We manage the life-threatening injury first. During this, we only immobilize the fracture ends, and when the patient gets stabilized, later on we can do a definite treatment for the fracture. If we have only an isolated fracture and no other injury to the body, we can go straight away with the definite treatment. And if we have a fracture along with some other injuries, especially life-threatening injuries, we first save the life of the patient by resuscitating the patient with ATLS protocol, putting the chest tube if there is pneumothorax, and supplanting the limb if there is closed fracture. Why we supplant the limb? To make the fracture ends immobilized. Why it's necessary to immobilize the fracture ends? Because moving fracture ends can lacerate the artery, can lacerate the nerve, can do further harm, further damage to the muscles and skin. When we immobilize the fracture ends, the further insult to the body is stopped. This minimum treatment which we do for the fracture in emergency cases, that is called damage control orthopedics. And when patient gets stabilized, we do the definite treatment. Furthermore, extremity trauma not only involves the bones, most obviously through a fracture, but also involves the surrounding soft tissue envelope and thus could describe injuries to the nerve, other connective tissue and skin. The goal of extremity trauma management is to return the injured area to optimal function as quickly as possible and therefore return function to the patient. The aim of the management is to optimize the functional outcome. We need functional outcome and we want to optimize the functional outcome for the patient. The management of extremity trauma is stepwise and involves initially saving the patient's life by identification and treatment of life and limb-threatening injuries according to ATLS protocols. First, we address the life-threatening injuries, then limb-threatening injuries, and then the minor injuries. Life-threatening injuries we have already discussed. What are limb-threatening injuries? The vascular supply of the limb. For example, thrombosis of the popliteal artery can cause gangrene of the calf and foot and can result in amputation. That is limb-threatening injury. Life is important than limb. First life, then limb. They put the injury into context, attributing to it a priority in the management of all the patient's injuries. For example, a traumatic hand injury may require management before operative femoral fracture stabilization with an intramedullary nail. Intramedullary nail is definite treatment for the femur fracture, and if we have head injury along with it, we won't go with the definite treatment for femur because we have a head injury. That is more important. We'll first address the head injury and only stabilize the femur with traction. With traction, the femur fracture ends will become immobilized and we can operate for head injury. And when the patient will get stabilized, later on we can put the intramedullary nail in the femur. That is the definite treatment for the femur. Therefore, the context of extremity trauma is extremely important. Applying the principles of ATLS in the initial assessment, followed by damage control orthopedics in the ongoing surgical management, provides a framework for patient's management. So this is the framework for patient management. First, address the life-threatening, then limb-threatening, and then minor injuries. One could summarize this by noting that treatment depends on patient factors, injury-specific factors, surgeon factors, including the resources available. Treatment depends on patient factors, injury-specific factors, surgeon factors, and available resources. What are the patient factors? For example, if we have femur fracture in a kid, the treatment would be different. In an adult femur fracture, treatment would be different. And in a moribund patient, treatment would be different. Same fracture, different ages, different patients, different treatment. Injury-specific factors. For example, if we have fracture of the tibia and it is closed, treatment would be different. And if it is open, treatment would be different. For open, we apply external fixation. We do external fixation. For closed, we put intramedullary nail. Surgeon factors. The expertise of the surgeon are also important. For example, if we have suprapendular fracture of the femur, there are different treatment modalities like retrograde intramedullary nail and distal femoral locking plate. The treatment option should be adopted in which the surgeon have most expertise. And available resources are also important. For example, if we have closed fracture of the femur, we can manage it with closed intramedullary nail in which image intensifier is needed. If we don't have image intensifier, we cannot do closed nailing. We will opt for open intramedullary nail. So available resources are also important. It is pertinent for the clinician to involve the patient in the decision-making process when it comes to the treatment for that individual. Moreover, treatment priorities, functional demands, and risk versus benefit vary from individual to individual. So now we come to diagnosis. The diagnosis of extremity trauma begins with the taking of a pertinent history. So, first history, then physical examination, then special tests. So first of all, we discuss history. You all know that a good history taken is half the job done. It is important to ascertain the mechanism of injury. The mechanism of injury. Because mechanism of injury tells a lot. If the patient gives history of fall, We know that there can be the fracture of the calcaneum, fracture of the neck of the femur, and fracture of the lumbar vertebra. And if patient gives history of a head-on collision, we know that there can be posterior dislocation, dashboard injury. History gives history of dashboard injury. We all know that there can be posterior dislocation of the tibia or posterior dislocation of the femur. So mechanism of injury is important. And then comes the force involved in the injury. If a huge force dissipates in trauma, there can be multiple injuries. If there are head-on collision of two big vehicles, there can be multiple injuries. And if the injury dissipated is low, there can be only a few injuries. Take time to gather sufficient detail in order to do this. The mechanism of injury gives an indication to the clinician of the energy and forces imparted onto the patient. Certain injury mechanisms result in classical injury patterns, for example, electrocution, electric shock, or seizure. Activity may lead to a posterior dislocation of the shoulder. We all know that anterior dislocation of the shoulder is most important and posterior dislocation of the shoulder is rare, and it only occurs in cases of seizures or electrocution because of forceful contractions of the big muscles around the shoulder. In your mind, translate the mechanism of injury into the common anatomical injury patterns. For example, a head-on collision between two cars, each traveling at 40 miles per hour, coming to a dead stop, should be interpreted by the history taker as a rapid deceleration injury. And we know that in deceleration injury, there can be rupture of aortic arch. Similarly, a fall onto an outstretched hand might be associated with wrist, elbow, shoulder, or clavicular injuries. Following the history of the presenting complaint, it is important to collect information beyond that of injury. The mnemonic is AMPLE. A for allergies, M for medications like anticoagulant, antiplatelets, corticosteroid use, or any other possible immunosuppressant treatment. We have to stop the anticoagulation before the operation because it can result in massive blood loss. P for past medical and surgical history. L for last time when patient has eaten or drink, because it is important for anesthesia point of view. E for events that led to injury. In multiply injured patient or patients with altered level of consciousness gain as much collateral history. Collateral history is the history given by the attendants or the onlookers. Listen to the account of pre-hospital personnel. For example, the amount of cabin intrusion in a vehicle. If there is a cabin intrusion which shows a large force dissipated, or whether a collision was a head-on or side-on. Examination. An initial general examination including vital signs and general assessment should be conducted. First of all, vital signs and general assessment. Then, is this an isolated injury, or do you have to start right at the beginning considering the ABC approach as advocated by ATLS? Examination of the individual extremity only begins once you have made sure the patient is stable and limb and life-threatening injuries have been ruled out. It is crucial to undertake a thorough head-to-toe evaluation in the secondary survey. Often the minor extremity injuries are missed that should be diagnosed or that should be confirmed in tertiary survey. First ATLS, then secondary survey, head-to-toe examination, detailed evaluation, and then the tertiary survey for minor injuries. A top-to-toe evaluation is achieved by a systematic approach, which include look, feel, move, special test, and special investigations. What is the systematic approach? Look, feel, move, special test, and special investigations. Look is inspection, feel is palpation, then move, special test, and special investigations. Can you name some of the injuries which are notorious for being missed? You may all know the scaphoid fractures. Some other are posterior dislocation of the shoulder, which we have just discussed, the lateral condylar mass fracture of the distal humerus, perineal dislocation, tarsometatarsal fracture dislocation, compartment syndrome, which is a true orthopedic emergency and can result in the loss of the limb if it is not timely diagnosed. Vascular injury with knee dislocation. A knee dislocation, especially the posterior dislocation of the knee, can damage the popliteal artery. In 30% cases, knee dislocation is associated with arterial damage, popliteal artery damage. Talar neck fracture is also a missed injury. Slipped upper femoral epiphysis in kids is another missed injury. Achilles tendon rupture. So, look for them. Ensure you examine the joint above and the joint below the site of injury. The rule of two is very important in orthopedics. The joint above and joint below the injury. Consider the events and mechanism of injury and examine the areas that could possibly be affected. For example, a patient who falls from a height may fracture the calcaneus, which is an obvious diagnosis with a very swollen hindfoot extremely tender heel. The concomitant lumbar spine fracture may not become evident until a few days later, when the distracting pain in the heel starts to subside. So, you should know the patterns associated with specific mechanism of injuries and should also look for them. With fall, there is an obvious injury, that is the calcaneum fracture, but there can also be the other injuries like lumbar fracture, lumbar vertebra fracture, lumbar spine fractures. Also look for them. Then comes the look. Also we can say it, the inspection. It is important to look at the whole limb, back and front, noting any localized swelling, bruising or any obvious deformity which will indicate the injury. A shortened externally rotated leg is in an older patient suggests a fracture of the proximal femur. When the femur fractures, the limb becomes shortened due to the pull of the quadriceps and externally rotated due to the action of the iliopsoas. A slightly flexed, adducted, internally rotated leg might suggest a posterior dislocation of the hip. What are the findings in posterior dislocation of the hip? The mnemonic is FADR, FADIR. F for flexion, A for adduction, AD for adduction, I for internal, R for rotation. So in posterior dislocation of the hip, the limb will be flexed, adducted and internally rotated. Any break in the skin or abrasion needs to be noted and the treating orthopedic surgeon informed, even if you do not think it communicates with the fracture. A graze over the knee in a closed tibial fracture may preclude intramedullary nail until the wound has healed over, or perhaps an alternative treatment may have to be considered. When there is a wound over the knee, we cannot do intramedullary nailing of the tibia, because the entry point of the intramedullary nail for the tibia is through the proximal tibia, through the knee. And when there is a wound or infection, it will make the whole nail and the fracture site infected. So we cannot go for intramedullary nail. We can either wait for the infection or the wound to heal, or we can opt for other treatment options like plating, which have incision site at the fracture site. Ideally, a photograph should be taken to document the injury and obviate the need for repeated manipulation of the dressing. When the patient comes in emergency with open wound, we should take the photograph and attach it with the file of the patient, because when the patient goes to the ward, other doctors want to see the wound and they have to open the dressing. And if we have already taken the photograph of the wound, every visiting surgeon can see that and there would be no need to open the dressing repeatedly. So take a photograph of the wound. Note the color of the limb and the degree of journal swelling. The color is important, which indicates the perfusion of the limb. If the limb is pale, there is less perfusion or no perfusion, and if the limb is pinkish, there is a perfusion, good perfusion, and the degree of general swelling, which indicates the amount of injury, the severity of injury. A compartment syndrome may still be present even when a limb does not appear to be swollen. Usually, in compartment syndrome, the limb is swollen, but it can also occur when the limb is not so swollen, because the posterior compartment of the leg, deep posterior compartment of the leg is deep and it cannot be palpated. But if it is grossly swollen, note, document, and pass on the information. Look for pre-existing scars. A scar at the back of the elbow or over the cubital tunnel might signify an anterior transposition of the ulnar nerve. Scars might signify previous metalworks that remain in situ or has been removed in the past. Then comes the feel, the palpation. Start gently examining the limb away from the zone of obvious injury. The rule is start from the normal to the abnormal. In this way, we will gain the patient's trust and gather as much information as possible and without causing the patient pain or discomfort. Feel for bony tenderness and note the degree of swelling and tenseness of the compartment. It should be noted that it is not possible to exclude a compartment syndrome based on how tense the limb feels. We have also already discussed that. The deep posterior compartment of the lower leg cannot be felt when palpating the skin because it is deep. The characteristic crepitus of subcutaneous air can be felt in the setting of open fractures, air jet injuries, and around the chest in the presence of a pneumothorax. Crepitus can be felt in the presence of a pneumothorax. The examiner should feel for pulses and assess capillary return. When there is a fracture, first we palpate for the pulses. When there is a fracture of the tibia, we palpate the dorsalis pedis and posterior tibial, whether there is any vascular injury associated with the fracture. And if we don't feel the pulse, then we go for the capillary refill. How we check the capillary refill? We press on the nail of the toe and press it with moderate pressure for 5 seconds, and then we leave it. When we compress, the nail blanches. It becomes pale, and when we leave it, release the pressure, it again becomes pinkish. The time should be 3 seconds or less. If it is more than 3 seconds to become pinkish, it is called the delayed capillary refill. And if it don't become pink at all, then there is no capillary refill. Then we check the temperature and compare it with the contralateral limb, and we document all these things. Then we come to the movement as part of the examination should once again be approached carefully and without causing the patient pain and discomfort. 2 types of movement can be assessed. One is active, the other one is passive. Active movements are those movements which are initiated and maintained by the patient. If we ask the patient to flex the elbow and patient flexes the elbow, it is active movement done by the patient. Passive movements are those which are done by the examiner. And then comes the special tests. There are often special tests to detect injuries in precise anatomical location, and many are described elsewhere in the book. For example, looking for a ruptured Achilles tendon by placing the patient prone with the foot over the edge of the bed and squeezing the calf. The plantar flexion of the foot and ankle then suggests the Achilles tendon is intact. What is this test called? This test is Thompson test. As we all know that the gastrocnemius and soleus muscle join together and form the Achilles tendon, and it gets inserted onto the heel, the calcaneus. And when we compress the calf, the gastrosoleus complex, the tendon gets contracted and the plantar flexion of the foot occurs. This shows the intact, that the Achilles tendon is intact. And if we compress the calf and the foot don't get plantar flexed, the Achilles tendon is ruptured. The examiner should be aware of gravity simulating active movements. We should be aware of the gravity simulating active movements. For example, if the patient is supine, the gravity can plantar flex the foot. So it is necessary to make the patient prone before doing Thompson test for Achilles tendon to rule out the gravity. effect. For example, a leg lying flat, fully extended on the couch does not mean the extensor mechanism of the knee is intact. In another example, uh, if the patient is lying flat, the limb will get extended with the gravity. This does not mean the extensor mechanism is working. What is the extensor mechanism? The extensor mechanism has four components, which are the quadriceps muscle and its tendon. Actually, three components: the quadricep and its tendon, the patella and the ligamentum patellae, and they make the leg extended. They extend the leg, and if this mechanism is working, the leg extension will be perfect and okay. And if the extensor mechanism is damaged, patient cannot extend the leg. In all knee injuries, make sure the patient can actively straight leg raise. So we ask the patient to raise the leg when it is extended and get their leg off the couch to exclude the gravity. Similar pitfalls exist in the upper limb with gravity straightening the elbow. In order to assess tricep function and elbow extension, ensure that the patient can actively extend against resistance from the examiner or against gravity. So we should be aware of the gravity. Beware of trick movements. What are trick movements? When a muscle is paralyzed or its function is lost, the patient learns to compensate for its function with some other muscles which are closely related to this muscle. For example, if a patient has complete rupture of the quadricep, he can still walk with the leg locked in full to slight hyperextension by using the iliotibial band. He is getting the function of quadriceps to some extent with iliotibial band. It is called trick movement, and patient learns this over the period of time. Patient with complete rupture of the Achilles tendon can still actively plantar flex the foot and ankle using the long toe flexors. These are the trick movements. When examining the patient, you should be aware of the trick movements, whether he is using the other muscles or it is actually the Achilles tendon itself. So it is important to be aware of the trick movements. Then comes the neurovascular examination. It is an important part of the extremity examination, and summary terms such as neurovascularly intact are best avoided. When we examine the patient and we say neurovascular bundle is intact, we should avoid this. And it is preferable to clearly document the examination performed and its findings along with a conclusion about the function of the particular neurological or vascular anatomy tested. On occasion, you may not be able to examine all movements because of injury or casts. When patient has acute injury or he has a cast applied, we cannot examine all the movements. It is important to examine and document findings before and after any manipulation or cast application to ensure no change. Again, the rule of two. We should examine and document the finding before the procedure and after the procedure. For example, a patient comes with posterior dislocation of the hip and we want to reduce the hip. We will check the sciatic nerve before the procedure and we'll document it intact or not, and then after this reduction of the dislocation we will again check the sciatic nerve and will document it. Similarly, with the dislocation of the knee, we know that there can be damage to the popliteal artery or peroneal nerve. We will check them before the reduction and then after the reduction, and similarly before applying a cast. For example, there is a fracture of the shaft of the humerus. We know that there can also be a radial nerve injury associated with the humeral shaft fracture. We will check it before applying a cast and after applying the cast, because if the radial nerve injury is associated with fracture, we can expect to heal it on its own, which is called expectant treatment, because radial nerve recovers in 90% cases with its injury associated with humerus shaft fracture. And if the radial nerve injury function has lost after application of cast or brace, then it should be explored. Then there is no expectant treatment. Most peripheral nerves have a motor and sensory component. Document both sensibility and motor function. Laceration or rupture of major vessels may result in life and limb-threatening injuries and should be dealt with an emergency. Complete laceration or occlusion of a major vessel is obvious and seldom missed. In contrast, occult vessel injuries must be considered and actively excluded. In 30% of knee dislocation, tibiofemoral dislocation, a vascular injury will occur. So, we have to look for occult vessel injuries. We all know that when there is posterior dislocation of the knee, there can be popliteal vessel injury. We should examine it repeatedly for 24 to 48 hours, and we are going to discuss it in the text following. The presence of palpable pulses does not exclude a significant vascular injury, and an intimal flap may develop, progress, and thrombose over time. Repeated evaluation is necessary before and after an intervention, for example, a manipulation or cast application. We all know that if there is complete injury to the vessel, that is obvious and that is seldom missed. And if there is only an intimal flap, that can be missed at the first instance because there will be a palpable pulses. And when this intimal flap will progress and will thrombose over time, then it will become evident and then it can be too late. So repeated evaluation is necessary in the first 24 to 48 hours. In injuries commonly associated with vascular injuries such as knee dislocation, occult injury should be actively excluded with an angiogram. If an angiogram is not performed, repeated thorough vascular evaluations of the limb should be undertaken for the first 24 to 48 hours. The best is we should get an angiogram when we fear there can be vascular injury. And if we cannot get angiogram due to any reason, unavailability, then we should perform repeated thorough examinations for the first 24 to 48 hours. Open fractures also demand attention to the neurological and vascular status of the limb. In the more severe injuries, there may be both neurological and vascular injuries requiring immediate surgical attention through rapid spanning of the limb, creation of an arterial shunt to provide urgent inflow, and subsequent vascular grafting. Once flow has been restored, usually at the same or another surgical setting, the fracture can then be stabilized definitively and appropriate soft tissue cover. Performing the arterial shunt before temporary stability has been achieved can compromise the later arterial reconstruction as length, rotation and alignment would not have been restored, thereby pulling on the graft. Open fractures require multiple specialty inputs. Now, what is the summary? Summary is that if we have any vascular injury like injury to the popliteal artery, first we will span the bone and fix it, then we will repair the artery, we will repair with the graft, and then later on we can do the definite treatment for the bone and cover the soft tissue, skin coverage. If we do the vascular grafting before fixation of the bone, before temporary fixation, that is the external fixation or spanning of the limb, we do vascular grafting and then we want to do the spanning of the limb, then there can be traction on the vascular graft and it may fail. So first we apply the external fixator, then we do the vascular grafting. For injury at the level of the wrist, what will be the order of the repair? And if we want to re-implant the amputated hand, what will be the order of repair? The order is B, fan, of Vrinder Sehwag. First, B for bone, E for extensor tendons, F for flexor tendons, A for artery, N for nerve, V for veins, and S for skin. What is the order of repair? First bone, then extensor tendon, then flexor tendon, then artery, then nerve, then vein, and then skin. So this is the order of repair. Investigations. The mainstay of extremity trauma investigation remains radiography of the affected limb to see if there is a bony injury. However, this is not the sole investigation available. The most important investigation is radiography, the X-rays. But there are some other investigations. Hematological investigations. Simple hematological investigations are seldom useful in the evaluation of a single limb injury. In polytrauma patient, a full blood count, serum biochemistry, clotting factors, and creatinine kinase may be useful. Why creatinine kinase? Because it indicates the degree of damage to the muscle. Why full blood count? To estimate the blood loss. Serum chemistry. Why are our renal function tests? Because in crush syndrome, when there is a damage to the muscle, myoglobin can damage into the nephrons, tubules of the kidney, and it can damage to the kidneys. So serum biochemistry is also important. A blood gas including pH, blood base excess, and lactate can be useful to show the severity of the injury and response to resuscitation. Ultrasound is also very useful to define soft tissue injuries. Fractures of the bone can be visualized on ultrasound, but generally it is reserved for the soft tissues. One limitation of ultrasound is the variability depending on the experience of the sonographer. Radiography. Radiographs are the mainstay in the initial evaluation of suspected extremity trauma. The rule of two should be remembered. Rule of two, which is most important. Rule of two. What is the rule of two? Two views for a fracture. Two views. Ensure acquisition of two views in orthogonal planes to avoid missing a fracture out of plane on the first radiograph view. For shoulder injuries, ensure at least an anteroposterior and axillary or modified axillary view. For tibia, femur, radius ulna, there would be anteroposterior and lateral view. First two views, then two joints. Radiographs are required of the joint above and joint below the fractures. Two joints. Two occasions. Sometimes the fracture may not be initially visible. A second series of radiographs should be undertaken after 10 to 14 days if suspicion of bony injury persists. For example, patient gave history of fall onto an outstretched hand. In the first X-ray, there is no fracture seen, and still patient complains of pain in the anatomical snuff box after 10 to 14 days have passed. Then we should repeat the X-ray. If initial scaphoid views are normal, consider repeating them 10 to 14 days later if pain and tenderness in the anatomical snuff box persists. And I will add that if we are going to do any manipulation, like patient has come with hip dislocation, we'll obtain an X-ray before the manipulation and after the manipulation. Two sides. In pediatric patient, it can be useful to consider a radiograph from the opposite and uninjured side if doubt exists, because in pediatric patients, there are open physesis which may mimic a fracture, and we can also get the X-ray of the contralateral limb to match it, the normal anatomy. With improved access to atlases of normal variants, this is less important now. Now we have atlases and a lot of X-rays available. So the need for the contralateral limb X-ray is now less important. Then comes the CT scan. CT axial tomography (CT) is very good for characterizing the bony anatomy of injuries, allowing for multiplanar reconstruction of injury anatomy and providing other 3D information. It is very useful for periarticular injuries, where the exact characterization of bony injury is essential. In periarticular injuries, while operating, we need to restore the exact anatomy of the articular cartilage, because a few mm step of articular cartilage can lead to osteoarthritis later on. So it is very important. A CT scan with contrast creating a CT angiogram provide very useful information regarding the vascularity and its association with the fracture. The CT angiogram also gives an indication to plastic reconstruction surgeons of reconstructive options for limb trauma. CT angiogram is also important to plastic reconstructing surgeons because they do flaps, and flaps are based on arteries. And CT angiogram tells about the arteries, vessels. Surface volume rendering is a useful addition following for easier visualization of an injury. Surface rendering and volume rendering are two modalities used in radiology for 3D reconstruction. CT angiography may be added, providing information on the vascular anatomy. One disadvantage of the CT is the dose of radiation involved. What is disadvantage? Dose of radiation involved. How much radiation is involved in one CT? It is equal to 400 X-rays. It is equal to 400 X-rays. MRI, then comes MRI. Magnetic resonance imaging provides 3D information about the radiation involved in CT. It provides useful information particularly about the soft tissues. MRI can provide information on the blood supply to the bone. Blood supply to the bone. For example, avascular necrosis of the proximal pole of the scaphoid. Do you know why always the proximal pole of the scaphoid gets avascularly necrosed? Because the blood supply of the scaphoid is in retrograde fashion from the distal pole to the proximal pole, and when the scaphoid gets fractured through its waist, the proximal pole is the first to get rendered avascular. One disadvantage of MRI is the time taken to acquire the image. It is time-taking procedure. Patients suffering from claustrophobia find the experience traumatic. Now the open MRI have also come, and it may alleviate some sufferings of the patients suffering from claustrophobia. It is essential to ensure patient safety, and consideration should be given to potential risks of MRI that may apply. What are the potential risks of MRI? Those are for patients having implants in their body, like foreign bodies, implants in the eye, cochlear implants, intramedullary nails, plates. Nowadays, most orthopedic implants are MRI compatible. Do you know the phenomena of ferromagnetism? The metals having phenomena of ferromagnetism are not compatible with the MRI. Which are those metals? First one is iron, then nickel and cobalt. These metals are not compatible with the MRI. Titanium is compatible with MRI, and latest orthopedic implants are made of titanium. And the implants which are well fitted can get MRI. Loose implants, patients with loose implants should avoid MRI because they can migrate. And do you know what is the field strength, magnetic field strength of a clinical MRI? That is usually of 1.5 to 3 Tesla. And the MRI is used in research for research purposes have far greater magnetic field strengths, as much as 17 Tesla. Those MRIs are real risk for patients having implants in their body that can cause implant loosening, implant migration and heating of the implant. MRI angiography can also be performed providing information about the vascular anatomy. Then comes nuclear medicine scans. Technetium-99 nuclear medicine scan register osteoblastic activity and may be used to demonstrate occult fractures, for example, an undisplaced scaphoid fractures. What does that mean? The technetium-99 is a nuclide which is attached with the pharmaceutical agent and injected into the body, and it is absorbed by the osteoblasts. Where the osteoblasts are found? Where the bone is being formed? At the fracture sites, at the metastasis, in the tumors. So where the technetium along with the pharmaceutical agents gets absorbed in the body, and they emits gamma rays which are detected by the gamma camera, and where the maximum concentration of technetium-99 is present, we can suspect any fracture or metastasis or tumor there. So it is very important investigation. This is the example of a missed posterior dislocation of the shoulder. This is AP view, and we see that there is perfect glenohumeral contact and it is easily missed. This is lateral scapular view, and in this view we can see that there is slight posteriorly directed humeral head, suspicion of posterior dislocation but not confirmation. And this is axillary view. In this view we can clearly see that there is a posterior dislocation because it is glenoid and it is humeral head, posteriorly dislocated. So this is the importance of two views. This is posterior dislocation of the anterior dislocation of the knee joint. Tibia is dislocated anteriorly, and there is disruption of the popliteal artery. This is the surface anatomy of the anatomical snuff box. Number 1 is bluish vein, cephalic vein. Number 2 is yellowish radial nerve. Number 3 is red radial artery. Number 4 is distal end of the radius. Number 5 is scaphoid. Number 6 is trapezium. Number 7 is metacarpal. Number 8 is proximal phalanx. Number 9 is distal phalanx. Number 10 is extensor pollicis longus, which gets attached to the distal phalanx. Number 11 is extensor pollicis brevis, which attaches to the base of the proximal phalanx. Number 12 is abductor pollicis longus, which attaches to the first metacarpal. So in summary, what are the important points? Follow a systematic approach. History requires sufficient detail of injury. History can be organized in the ample format. Examination follows look, feel, move, special test approach. Investigation will include radiographs with the rule of 2 observed. Selective use of special investigations can help diagnosis. Then comes the description and classification of the injury, which we will discuss in the next video. Thank you.